Good morning and welcome to Cyprus, which is my new home after having spent many years in America and in the Middle East. I'm going to talk to you about how accurate are our diagnostic tests for reflux and obstruction. I want to come back a little bit to the pathophysiology and some differences between the arterial side and the venous side. And most of us have a lot of experience from the arterial side and try to transfer concepts to the venous side, although this might not always be correct. So the arterial side is a low volume, high pressure, pulsatile system, and what we are interested in is patency. And it's sort of a plumbing system that clogs up or not. On the venous side, on the other hand, we have a high volume, a low pressure, and a phasic flow that is regulated more or less by the breathing, and it's really chaotic and not laminar that it is on the arterial side. And not only do we have a problem with blockage, we also have the valve function, competency. So if we look at the old model that we have, chronic venous disease depends on obstruction and reflux. It leads, as we heard, to venous hypertension and eventually may lead to ulcer. But when you look at the reflux is very dependent on the calf muscle pump. And the calf muscle pump is very dependent on the fact that you can move your ankle, that you have a muscle mass, and that you have some venous volume. When it comes to the reflux, you can have it in the deep system, you can have it in the superficial system, and you can have perforators connecting it. When we look at the obstruction, again, we have a proximal obstruction, maybe going above the inguinal ligament, and you have a distal one that maybe is just involving the calf or the femoral one, or femoral vein. And then you have collaterals, and what do they do with collaterals? Do they compensate for obstruction, or they just indicate an obstruction? And finally, we have, as we heard from Andrew, about the microvascular pathology. So this is a very complicated situation. And when we try to make venous tests, we have to be sure what we are measuring. For those who are taking pictures, all of this will be on the website that you can download later on after the meeting, so you don't have to take pictures of everything. Venous tests are either showing anatomy or function. We try to separate the reflux with the obstruction, and we want to know if it's a focal test for a part of the venous system or it's a global test. And the challenge that we have is that we want to identify the presence and degree of reflux and obstruction in each vein segment of the lower limb. And then we would like to find out how much does that vein segment contribute to the global hemodynamics. And that is a tough task to do. So when you look at the measurement, when you read papers about this, you need to know, what am I looking for in the test? Well, it needs to be an accurate test. It needs to be reproducible in the fact that it should show the same thing over and over again. It needs to be simple, otherwise we don't use it. And it needs to be pertinent, that it actually measures something that is of value. And it has to be unique, so that it separates reflux and obstruction, anatomy, etc. Right? And every test that we do need to be described in its accuracy, as we know, and the sensitivity and specificity. And this is very hard on the venous system. So what do we have as a gold standard? Well, we don't have a lot of gold standards when it comes to venous tests. Now, when we create a test, we want to compare, for example, normal limbs with venous disease of different kinds. All right? And then we can do accuracy, sensitivity, and specificity. And that is the best situation. Unfortunately, we cannot do that all the time. We can assess a test by referring it to the clinical impact. For example, in the outflow obstruction, when we treat it, we get the clinical improvement, and if we have a test that follows that clinical improvement, then it may indicate that it's a good test. On the other hand, we know that if we do valve repairs, we have little effect on the hemodynamic test that we use, so there's a dissociation between the clinical response and the test response. And that what is correct, the clinical response or the test response? And of course, it's the clinical response that is more important. We talked Andrew talked a little bit about perforators, and there we have the problem with cause-effect or just an association. A lot of us believe that the perforators are just innocent bystanders, and although they do increase with increased severity, that's not part of the pathophysiology. So most tests that we actually use to look at a group of patients compared to another group of patients, and we try to separate those two groups with the means and averages. But that doesn't tell you if a test can put the patient in a group that has disease of a certain kind or not. And that is something you have to think about when we use the test. Now, when we look at the test, we have hemodynamic tests. They are invasive, like the ambulatory venous pressure and the femoral venous pressures. And we have non-invasive. Of course, the golden test, the duplex Doppler scanning, that's most commonly used, but also different kinds of plethysmography. That is hemodynamic step. And then we have morphological tests that can show what it looks like anatomically. Transfemoral venogram, intravascular ultrasound, and on the non-invasive side again, duplex Doppler and CT and MRV. Now, duplex ultrasound is of course the one that is most commonly used, and it's the first test that should be done. And that is a test for segmental reflux and obstruction. It should be used in erect position. You can use manual or mechanical compression. And we have all accepted the fact that if you have a duration of reflux that is more than half a second, is pathological. In the new recommendation of the American Venous Forum that came out regarding varicose veins, we are now putting the limit on the FEMPOF segment to more than 1 second, and a pathological perforator has been identified as an outward flow of more than 0.5 seconds, the diameter more than 3.5 millimeters, and the perforator should be around an ulcer or a healed ulcer, active or healed ulcer. And duplex ultrasound shows us the morphological criteria for obstruction only. We don't have any test otherwise for the obstruction. So what you can see with duplex is that we have reflux here, we have obstruction here, and then you can make a multi-segment score. And we know that the more segments of the lower limb that are involved, the more severe disease you have. The parameters that you can use, now the reflux time that you see here is the usual duration of reflux. Then you have a peak reflux velocity, which is the one that you see here, when you pump it up further and then it comes back, and the peak shows you the peak reflux velocity. You can also measure the area here, and that gives you the time average reflux volume flow. And if you can get a good crosscut area, you can actually measure the rate of reflux in milliliters per minute. Now, what we know about these parameters is that the duration of reflux is not related to the severity of reflux. So if you have a reflux that is 15 seconds, it doesn't mean that it is worse if one you have that is 10 seconds. And these are papers that all show that other factors than the duration of reflux are important, such as peak reflux volume, flow, peak reflux velocity, the fact that you have an axial reflux that involves both the femoral vein and the popliteal vein is more important than if you have a segmental reflux. We did a study where you took the level of a knee and you added up all the parameters, at that level, which meant that you have a short saphenous, small saphenous vein, gastrocnemius, popliteal vein, and great saphenous vein. And then we just added up the duration, we added up the plethysmographic test, etc. And when you look at this, we took a group of C class 1 to 3, meaning up to swelling, and then 4 to 6, which means that you have starting having skin changes, right? And these two groups, we were looking at separating these two groups. And if you see here that when you look at the ambulatory venous pressure, the venous filling time, the venous filling index, it all showed that there were significant differences as a group, average, in between these two. But when you look at the reflux time, or the duration of reflux, there was no significant difference. On the other hand, if you took other ultrasound parameters, like the PRB and the TAF, then there was significant difference. So my message to you is, duration of reflux doesn't show severity of reflux. This is another study that sort of looks and tries to see how the deep reflux affects the superficial reflux. What they did is that they looked at the deep system in the femoral-popliteal axis, and what they call P reflux flow at 5 seconds, where the arrows are, that was the maximal reflux velocity. And then they had a component of the deep system and superficial incompetence, and they ablated the great saphenous vein. And on the left-hand side, you can see that before, and then they divided the two groups into low MRV and high MRV by the 10 centimeters per second. Now, before it showed that the VFI was higher when the deep system was involved, and on your right side, the VCSS was higher when the deep system was involved. Then they operated the patient, and lo and behold, those people that had a higher reflux flow in the deep system, they came out having less decrease of the venous filling index and less impact on the venous severity score. And this is a way of trying to see what the impact of the deep system is on the superficial system when you only take care of the superficial system. So in conclusion, regarding duplex ultrasound, longer reflux time is not related to severity of reflux, and peak reflux velocity and reflux flow are probably better, but very hard because it is a variable when you do those tests. Ambulatory venous pressure has been considered the golden standard, a global hemodynamic test, and we all know about does that work? We know that we have the pressure here, and the pressure drop is one factor, and then the venous filling time is one factor. And of course, with the disease, you have a less drop and a longer, a shorter period of filling up. And we know that this is related to the incidence of ulceration. However, there is a group here that has normal venous pressure and still have ulceration, and there is a group up here that has high ambulatory venous pressure but doesn't have any ulcer. And if you put a catheter in the dorsal foot vein to measure the ambulatory venous pressure, you put another catheter in the calf vein, for example the posterior tibial just below the popliteal vein, and you put one in the great saphenous vein, and you measure this simultaneously, you will see that you have a very nice curve here that shows that the ambulatory venous pressure is normal, but in the calf the pressure actually goes up and there is no drop in the great saphenous vein. So it's doubtful that the ambulatory venous pressure reflects all what is going on in the lower limb. So I don't consider this a global gold standard anymore. And abnormal ambulatory venous pressure does not always result in detectable symptoms, and vice versa. Air plethysmography, I don't know if you are familiar with. You put the bag around the limb in a lying down patient and let him stand up quickly, which means that he dumps all his blood into that leg, and the bag will react to that volume increase. And you get a curve like this. This is lying down, he stands up, then he does one toe stand, which makes the blood be pushed out, and then it can do 10 of them, and it comes down to this region here. Now, this is a global hemodynamic test, and it can differentiate between reflux and calf muscle pump function to a certain degree. It's a good research tool. The only part of this test that has been really validated is the venous filling index. There is a belief that the residual volume fraction is correlated to the ambulatory venous pressure, but when you go through lots of papers that have been written through the years, this is not true. And this is not strange, because volume is not necessarily related to pressure, because it depends on the compliance of the vessel that you put the volume in. Okay? So you can have a lower volume and a higher pressure buildup. Venous obstruction, we don't know at what degree a venous stenosis is critical. It's not like on the arterial side where we say 70% stenosis creates a higher resistance than the peripheral resistance, and that is therefore significant. On the venous side, we don't know at all, because we are going from a smaller vessel to a larger vessel, and the whole system converges towards the inferior vena cava, where essentially the pressure is zero. So logically, probably a venous obstruction is significant at a lesser degree than the arterial system. So it's not 70%, it may be perhaps 50%, but we actually don't know. And since we don't know that, we cannot create hemodynamic tests to evaluate the outflow obstruction. So we have to do really morphological tests. And one of those are the transfemoral venogram, which you can see here. This is an AP view with no subtraction, and you can see this a little bit of dissolution here, and you have a little bit of collaterals here. If you rotate the patient, you don't see very much more, but if you do subtraction, like in an angiography, you can clearly see the compression of the artery over the vein here, the collaterals, and both in the oblique and the AP view. Intravascular ultrasound is a test for focal morphological obstruction. It doesn't do anything else, but it's superior to venogram in this aspect, and it can identify accurately the presence, the degree, and extent of obstruction. And here we have an example of that. On the left-hand side, you have a patient with a non-thrombotic iliac compression, and on the right side, you have the IVUS, and you can see this is the IVUS catheter, and this is the vein. Now, normally, this is the way it looks at the crossing. This is the artery, right common iliac artery crossing the vein. This is the vein with the catheter inside. If you look at the right side now, you can see the vein, artery comes over and it compresses the vein. And you can see how significant compression that is versus that is. And when you put a balloon in there, this is the kind of wasting that you will get. And IVUS have been compared to transfemoral venogram. And I want to point out two things. One is that a normal venogram can be seen in 70% of these cases and in 25% of these cases, despite the fact that the intravascular ultrasound shows a more than 50 and more than 70% stenosis. And here you have a sensitivity and the negative predictive value, which is low. And even if you rotate the patient and take oblique pictures, you don't increase the sensitivity more than to 63% and the negative predictive value to 68%. So venogram essentially is not good to evaluate morphological stenosis. Duplex ultrasound has not been identified in the pelvic region very well, but as we increasingly use it, we get adjusted to it, and you can clearly see that this is a stenosis compared to the previous picture. The only paper is by Nikos Lavropoulos, who had looked at focal stenosis, and just like on the arterial side, he could find a post to pre-stenotic peak velocity ratio that was more than 2.5. But that goes into the focal if you have 5, 10 millimeters obstruction. If you have a long one like this, we don't know how that will play out. And this is with a stent, and you can see that looks like later. Later on during the week, we're going to hear about MRV, and I will not go into that. And we're looking at CT venograms, where you can see that this aorta right here divides up and compresses the vein that is underneath. Here you can clearly see the bone, the vein, and the artery that compresses it. And this will be shown more later on. And this is a nice little picture of how you can make up pictures with the CT venograms. And Harald is going to talk about this in a few days. So conclusions. The duplex ultrasound scanning is the primary venous testing tools. I think it should be routinely extended above the inguinal ligament, because otherwise you will miss lesions. Reflux time does not indicate degree of severity, and you should look at the PRV, or rate of reflux. Venous filling index by APG measures reflux, there's no doubt about that, and it correlates to the venous filling time, and it decreases after reflux surgery, showing that it's a valuable test to show that you have a result. The global calf muscle function is still ultimately measured by the APP, and what is interesting is that although we don't understand the role of ejection fraction, theoretically, if you have a good ejection fraction, your results should be better after surgery, and probably you can surely you can compensate for reflux by a good calf muscle pump and a good ejection fraction. And maybe that is why patients, when they grow older, when they lose movement of their ankle, calf muscle mass gets worse. Obstruction, we don't have any accurate tests. Even if tests are positive, it doesn't mean that you can exclude a venous obstruction. And you have to go on with some sort of morphological investigation in selected patients, which we can discuss later on. And IVUS, I think, is the optimal test for this. The future lies, however, in the ultrasound. And I think that as we get more experience, we will develop more and more tests that you can do with external ultrasound. So the challenge still remains. We cannot quantify reflux and obstruction in each vein segment. We cannot see how they contribute to the global pathophysiology, and we don't know how to direct the treatment in a complex situation in the venous disease. So we end up with that there are no absolutes in venous disease, unfortunately only in vodka. Thank you very much.